Good afternoon, everybody. I think we can go ahead and get started. This is Ashley from the Game Center. Just want to thank everybody for joining us today for our AOT Affinity Group Office Hours. Today's webinar topic is Promoting Community Inclusion and AOT Programs, Concepts and Approaches. We're happy to have Mark Salzer as our guest today, our guest speaker. Mark is a professor and former founding chair of the Department of Rehabilitation Sciences at Temple University. He has also been the principal investigator and director of the Temple University RRTC on community living and participation for people with serious mental illnesses since 2003. I want to take a moment to read our quick disclaimer. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. In our quick reminders today, please keep your phones on mute if you're not taking part in the discussion, and also please do not put your phones on hold as we may hear your hold music. And lastly, we are recording this webinar, and I'll be sending out the link early next week to everybody. I'll pass that over to Mark. Thank you.
Okay, great. Thank you very much, Ashley. It's a pleasure to have the opportunity to speak with everyone this afternoon about community inclusion and how community inclusion efforts can be incorporated into the great work that all of you are doing around the country. What I'll be doing this afternoon is addressing these objectives until about 55 minutes after the hour. And then we'll open it up for the last 20 minutes or so for questions, comments, and anything else that people would like to talk about. Please also feel free to use the chat function. I have the chat open, and if if you don't understand something or want clarification while I'm presenting, I'll either be able to see it or maybe Ashley will draw my attention to it. But otherwise, why don't we go ahead and get started. The three objectives that I will be talking about or hope to achieve today is to, first of all, briefly review the research underlying the importance of community inclusion and community participation for people with serious mental illnesses. And let me be clear that when I'm talking about community participation, I'm talking about work, going to school, dating, parenting, leisure recreation out in the community, religion, spirituality, voting, volunteering, basically doing things out in the community and supporting people with serious mental illnesses to do things out in the community like everyone else, and why this is important to the mental health, wellness, and recovery of people with serious mental illnesses. The second objective is to discuss some of the principles or fundamentals of community inclusion, some of the essential things that need to be incorporated into programs and supports that promote community inclusion and community participation. And lastly, I'll be mentioning some specific initiatives that have been undertaken, evidence-based initiatives that have been undertaken to promote community inclusion and participation and address these fundamentals for doing so, and especially the critical role that peer specialists can play in promoting community inclusion and community participation. In addition to these objectives, while I'm presenting this afternoon, please think about the following two things as it pertains to your work in your programs. The first question I'd like you to ask yourself are, what are the things that our program is currently doing to support people with serious mental illnesses in the community? What do we currently do to support people in work, going to school, dating, parenting, leisure recreation, housing, voting, volunteering, spirituality, and religion? What are we currently doing? And what are the challenges that we face in supporting community inclusion for people with serious mental illnesses? So I want to briefly introduce you to the concept of community inclusion. What does it mean? And introduce you to this document in particular, which provides further clarification on all the topics that I'll be talking about, on all the fundamentals. This document also includes all the references and citations to everything that I'm talking about this afternoon. So I'll mention this in a second. The first thing I'd like you to keep in mind when we talk about community inclusion is that community inclusion refers to two things. It refers to the opportunities for people with serious mental illnesses to live in the community and be valued for their uniquenesses and differences like everyone else. So this, again, refers to the opportunities to go to work, go to school, date, parent, vote, volunteer, leisure, recreation, religion, spirituality, anything that any of us, that anybody does in their lives. What are the opportunities for people with serious mental illnesses to do those same things? And again, in a moment, I'll be discussing some of the evidence about why this is essential for reducing symptoms and promoting wellness and recovery for people with serious mental illnesses. The second part of community inclusion is creating environments, communities that actually welcome and embrace people with serious mental illnesses. This specifically gets around reducing prejudice and discrimination that people oftentimes face when attempting to engage in the community. So we'll talk a little bit about those issues as well. This is a document that our center was asked to create for an agency in Australia called Wellways Australia. And Wellways asked us to create this document because in Australia there were some major changes going on in terms of their funding for mental health services and also changes in their disability insurance scheme is what they call it, funding for people with disabilities, kind of like our Social Security programs, those kinds of things. And they were looking for information or really looking to continue to promote community inclusion and participation for people with serious mental illnesses in Australia and wanted to make sure that these concepts remained present in the, while all these changes were happening in the policies in Australia. So they approached us and asked us to pull together the evidence base behind the importance of community inclusion and community participation, and also to articulate the fundamentals for promoting community inclusion. So this is what was behind the creation of this document that's called Well Together. You see the link at the bottom there where you can download this document. It's free and available for use and further dissemination. So again, please take the opportunity to take a look at it, and you'll be able to see again the evidence, the specific references to the things that I'll be talking about this afternoon. When Ashley in her introduction mentioned that I've been directing a center on community inclusion for about the last 15 years now, and this is a federally funded center funded by the National Institute on Disabilities, Independent Living, and Rehabilitation Research. And when I first started talking about community inclusion of individuals with serious mental illnesses, some of our provider colleagues and some policymakers would say, you know, Mark, look, the people that I work with are so impaired, have so many challenges in their lives related to their illness that they really, you know, they don't want to do this kind of stuff. They're not interested, they lack motivation, they experience anhedonia, which is the loss of pleasure and what would typically be enjoyable things. Our colleagues would say people I work with would not do this stuff. They don't want to go to work, they don't want to go to school, they don't want to hang out with friends, they don't want to do any of those things. Other people would say maybe they want to do this stuff, but they're so impaired they can't possibly do any of these things. So this is the couldn't. The people that I work with couldn't possibly do this kind of stuff. And the last thing I would hear from some of our colleagues is that people with serious mental illnesses shouldn't participate in the community like everyone else. People shouldn't go to work. People shouldn't go to school. People shouldn't date or parent or hang out with friends or go to church, synagogue, or mosque or do anything like that like everyone else. So that's the shouldn't part. So this is actually how we came up with the notion of wouldn't, couldn't, shouldn't. And in fact, the research suggests otherwise. We have pretty strong evidence that people with serious mental illnesses, including schizophrenia, spectrum disorders, bipolar disorder, and major depression, that people with these diagnoses indicate that they want to do these things. Not everybody wants to do everything, but that people are interested in participating more in the community. Our center has developed a measure called the Temple University Community Participation Measure. We've gathered data from about 3,000 people in various studies and evaluations and different type of efforts. And we consistently find that people with serious mental illnesses say they want to work for pay. They want to take classes. They want to hang out with friends. We also find that people with serious mental illnesses say that these are important to them and they're not doing it as much as they would like to do. So in this measure, we say how many days in the last 30 days do you engage in 26 different areas. We say how important is that specific area of participation to you, and then we ask them, do they do it enough, not enough, or too much? And we found substantial, more than 50% of people telling us that in each of these areas we ask them about, they say it's important to them, but they don't do it enough. Furthermore, there's been pretty solid research over the last 20 or 30 years that demonstrates when you ask people with serious mental illnesses what they want in their lives, they say the same top 3 things that people in the general population say they want in their lives. They want a good place to live. They want to engage in meaningful work. And they want intimate relationships. So they want this type of community inclusion and participation like we'll be talking about this afternoon. In terms of should and the evidence base behind, or could, the evidence base behind could, we like to refer to the fairly substantial research around programs such as supported housing programs and housing first programs, supported employment programs, supported education programs, and supported socialization programs. Those are efforts to promote interactions and relationships between people with serious mental illnesses and others, that all of these types of programs result in positive outcomes in these areas, even with people with very significant impairments associated with their diagnosis. So we have ample evidence that people with serious mental illnesses with the proper supports can participate in the community in a variety of areas. And then finally, the should area. Our center has started to talk about community inclusion and community participation as a medical necessity because there is ample research indicating that people who participate, people who work and go to school and date and parent and do things that they want to do in their lives, that this actually has positive mental health, physical health, and cognitive benefits. And we also have research that these benefits also occur for people with serious mental illnesses. And again, all of this research is covered in the Well Together document that I mentioned earlier. So, for example, what we refer to, you see here, it says participation makes everyone happy. There's research in the general population from the area of positive psychology where they have identified that the kinds of things that make people happy are intimate relationships, marriage and intimate relationships, friendships, work, and being around other people make anyone happy and increases wellness and well-being for anyone. And as you all know, these are all areas where people with serious mental illnesses are not participating to the same degree as the general population. So we're missing opportunities by not focusing on these areas, we're missing opportunities to promote mental health and wellness. I mentioned before, too, that we have findings in all of these areas that I've referenced. Again, that involve people with serious mental illnesses. We have evidence that people with serious mental illnesses who are working experience reduced symptoms, reduced hospitalizations, greater sense of self-efficacy and coping skills. And we find similar findings for individuals with serious mental illnesses who are going to school, in married relationships or intimate relationships, engaged in physical activity. Parenting is viewed as beneficial by people with serious mental illnesses. So again, unlike concerns that some of our colleagues have had about participation of people with serious mental illnesses, we actually find that, or the research indicates that people with serious mental illnesses who are participating are doing better than those who aren't participating. It occurs to me that I should actually mention one of the concerns that people have about participation of people with serious mental illnesses. The concerns that they have is that participation, going to work, for example, or going to school, causes stress. Stress leads to an exacerbation of symptoms. An exacerbation of symptoms leads to crisis, and crisis leads to hospitalization. And of course, we want to avoid crisis and hospitalization. And that is a reason that some people give for not promoting opportunities for people to participate in some of these activities. And I do like to point out or agree that work is sometimes stressful. My work is sometimes stressful. My parenting, I've got 3 sons, it was sometimes stressful. Now that they're older, sometimes it's even more stressful. But the bottom line from the research we've seen, however, is that people with serious mental illnesses who are engaged in all these areas actually have better outcomes or are doing better than individuals who aren't participating. And the last area that I mentioned that's related to participation is that participation has been found to be associated with cognitive benefits. This is incredibly important, especially when we think about individuals who have been diagnosed with schizophrenia. And there's ample research suggesting that schizophrenia is associated with cognitive impairments, especially memory and executive functioning. And for the most part, we attribute these impairments to the disease process or the illness process associated with schizophrenia. However, there's also ample research, especially in the general population, suggesting that aspects of participation are also associated with cognitive health, with memory, executive functioning, those kinds of things. And these are areas of participation where people with schizophrenia and other serious mental illnesses are not participating to the same degree as the general population. So let me give you 3 of these areas. The first one is physical activity. There's ample research that people who are less physically active, people who are engaged in sedentary behavior, which is lying down and sitting down for a long periods of time, that actually is associated with cognitive impairments. There are a number of biological explanations for this. One of them that I particularly like and I think is promising is that physical activity, being more physically active, actually generates an increase in what are called neurotrophic factors in our brains, and that those neurotrophic factors have been associated with cognitive enhancements or greater ability to think. So this is the kind of research that suggests that physical activity is associated with cognitive health. We have good research indicating that people with serious mental illnesses spend between 70 to 90% of their days engaged in that sedentary behavior. lying down and sitting down. And just like for anybody else, that will be bad for people's brains. That could partly explain some of the cognitive impairments that we're seeing. There is some research that people are starting to do with people with individuals with serious mental illnesses to demonstrate this connection. There's the second area that connects participation and cognitive health is loneliness. Loneliness and social isolation is now being viewed as a public health issue, and it's being found, among other things, to be associated with cognitive impairments, especially for older adults. We know that people with serious mental illnesses report being more lonely and isolated than the general population. People have smaller social networks and spend less time with those individuals in their lives, and that could also be a factor in cognitive health. And the last area of participation that's associated with cognition and cognitive health is poverty. There's some research by an individual named Eldar Shafir, who's a professor at Princeton University, where he's shown, he has a publication in Science and other studies, where he's demonstrated that poverty, the experience of poverty, is associated with cognitive impairments. And he attributes this to the challenges of multitasking, that people who are multitasking actually experience challenges with cognitive load, and they perform worse on cognitive tasks. Poverty is viewed as living every day, consistently multitasking, especially with essential life functions. Where do I eat? Where do I sleep? How do I live? How do I buy my cigarettes and food and all of those kinds of things? So it's viewed as consistent multitasking, and this could be another explanation for why we see cognitive impairments for people with serious mental illnesses. And obviously this suggests that employment in particular that can increase income for individuals with serious mental illnesses is important for reducing poverty. So this is important for the rest of our discussion. It's important for us to recognize that the promotion of community inclusion and participation has positive physical health benefits, psychiatric benefits, and cognitive benefits for people with serious mental illnesses. So what are the things that we need to do? What are the fundamentals for promoting community inclusion and participation? What are the things that we should be thinking about? I'm going to be talking about 7 of them today. The Well Together document actually includes 11 fundamentals, but for the sake of time, I cut out a couple of them. The first fundamental is community inclusion applies to everyone with a serious mental illness. This fundamental was generated by conversations I've had with some of our colleagues, again, where individuals would say the people that I work with are too impaired to be able to participate in the community. They're too sick, their illness is too severe, they're unable to participate in the community. And we have evidence, however, that individuals who had been believed to be incapable of living in the community, when we look at them later on, 5 years, 10 years, 15, 20 years, 25 years later, we actually find that these individuals are able to participate in the community. And they are able to work and are able to date and be in satisfying relationships with other people. And that's the idea that we can somehow predict who's able to participate and who is not able to participate. There's really no evidence that we're able to predict who can participate and who cannot participate. Most of that evidence comes from the employment field, employment of people with serious mental illnesses. One of the most consistent findings in that area is that the best predictor of employment success is interest in working. Individuals with serious mental illness who want to work, even with very significant impairments, are more likely to work than individuals who don't want to work. So motivation is the biggest and best predictor of one's ability to participate. Now, certainly, if somebody is acutely psychotic or in an acute manic episode or depressive episode, can't get out of bed, can't get dressed, all of these kinds of things, certainly it's going to be difficult to support participation at that particular moment in time. But most of the individuals that you're working with in your various programs are not in that current state. And we're not able to, therefore, predict who's able to do certain things and who's not. So what are the practice implications of this fundamental? The main practice implication, as I just mentioned, is that it's important for us to use motivation and interest in participation. Somebody saying, I want to go to work, I want to go to school, I want to spend more time with friends, I want to play more basketball or do other things with people out in the community, I'd like to date, I'd like my children back, all of these kinds of things, that motivation is the best predictor or likely to be the best predictor of one's ability to participate rather than our assessment, our clinical assessments or intuition about whether or not somebody is ready to participate. So that's fundamental number one. Fundamental number two is community inclusion requires seeing the person, not the patient. What I mean by this is what I'm referring to is that a number of years ago, I was doing some research on stories that mental health professionals and policymakers tell about people with serious mental illnesses. And in particular, somebody named John who was diagnosed with schizophrenia. I gave a group of providers a prompt where I asked them to write a story about a man named John who's 34 years old and has been diagnosed with schizophrenia. Have your story begin with, or your story should have can be anything about how John thinks, feels, and behaves. Start your story with once upon a time. And we received what I said were, when we analyzed these results, we found two types of stories that people would write. One we called the John the patient story, and the other we called the John the person story. The John the patient story focused on John's impairments and illness and diagnosis and hospitalizations and non-adherence with medications and homelessness and maybe involvement in the criminal justice system. Usually the ending of those stories, a good ending, was John was staying at his board and care and took his medication, and that was a good ending and was able to stay out of the hospital. That's what we called the John the patient story. The John the person story did not ignore the diagnosis of schizophrenia and problems associated with schizophrenia, but also included John's family and his relationship with his family and friends and what John wanted to do and what he was doing, sometimes with support of providers and sometimes not. And these we called the John the person story. These stories focus on more than just John's diagnosis and illness. And we believe that there's evidence to suggest that in order to successfully promote community inclusion and participation, we need providers and clinicians who are more likely to have that John the person schema in their heads when they're thinking about schizophrenia, for example, or other serious mental illnesses. One reason we have concerns about, one reason we believe that is based on research on what's been called the Pygmalion Effect. This is research in the education area where they found that students, let's say African American or black children in a classroom with a teacher who thinks that they'll never be successful, that black children, black students in the classroom, boys won't be able to sit still and will be naughty and do bad things and, get in trouble all the time, that a black student in that classroom with a teacher who has that perspective will perform worse than students in a classroom with a teacher that does not have that perspective. So there's research demonstrating that teacher beliefs about children, in this case black children, has an effect on the performance of those children. There's very similar research pertaining to teacher perceptions of girls, especially in math and science. So if you have a teacher who believes that girls' brains are different and they can't perform well, or their brains aren't structured to really do well in math and science, the girls in that classroom won't do as well as girls in classrooms where the teacher doesn't have those perceptions. And we believe that if we apply that in a mental health context, and there are providers and clinicians who believe that people with serious mental illnesses can't participate, can't go to work, can't go to school, shouldn't date, can't parent, all of these kinds of things, that will influence and actually bring out that lack of participation. In addition to there being more likely, or less likely, I should say, to support people's inclusion and participation. So our beliefs and attitudes about people, the ability of people with serious mental illnesses to participate likely affects their ability to participate. The last piece of evidence we have in this area is that mental health professionals have been documented to have very similar attitudes and beliefs about people with serious mental illnesses as the general population. That is, the very similar levels of prejudice and discrimination as the general population. So we do have these negative beliefs about people, and it's important for those to be addressed in order for us to successfully promote community inclusion and participation. So what do we do about that? The main thing that we need to do is change our schemas, how we view people with serious mental illnesses. And on this slide, I just referenced a couple of strategies that could be used. There does need to be more work in this area. The first one is a colleague of mine named Joyce Bell has developed an exercise where staff wear certain labels that we use for people with serious mental illnesses, things like non-compliant or unmotivated or those kinds of things, and that the experience of wearing those labels and describing how that makes one feel has an impact on, helps us understand what it feels like to be called these kinds of names. The second strategy that some people have talked about is having us tell our own stories about successful community inclusion and participation and recovery of people with serious mental illnesses that we're working with, to kind of remind us about all the positive things that people are capable of doing, instead of focusing on some of the challenges that people experience and that I know that you deal with on a daily basis in supporting individuals. So it's important for us to change those schemas. The third fundamental is that multiple domains of mainstream life should be thought. Basically what this refers to is that typically when we focus on supporting community inclusion for people with serious mental illnesses, we often focus on housing and employment, which are two critically important areas of community inclusion and participation, but they're not the only areas that people are interested in. That people are also interested in, again, dating and parenting and leisure and recreation and spirituality and religion and voting and volunteering and all of these other areas. So it's critically important for us to not just focus on housing and employment and say that we're done promoting community inclusion just because we focus on those two areas. We need to make sure that we focus on all areas that people are interested in. Fundamental number 4 is to make sure that we use current evidence-based support technologies, and I'll show you what I mean by that in a second, that we also promote the use and development of natural supports, and especially support and promote the use of peer supports for individuals with serious mental illnesses as well. So really use some of these evidence-based practices that have already been well established. I mentioned these support technologies. These are the types of things that I'm referring to. These are all principles underlying those programs, those evidence-based practices that I mentioned earlier. So supported housing, supported employment, supported education, supported socialization programs, all of these are evidence-based practices, and these are the types of technologies that are part of those practices. And these technologies can be applied in supporting someone in going to church if they want to go to church, in dating, in parenting, in doing other things that people want to do in their lives. So I'm not going to go through each of these technologies, but they should be familiar to you if you're familiar with these evidence-based practices. Natural supports, I mentioned earlier, are also important in the lives of people with serious mental illnesses and are important for promoting community inclusion and participation. What do I mean by natural supports? Natural supports are people who support individuals with serious mental illnesses who are not paid to do so. These would be friends, family members, co-workers, neighbors, people that they know in other settings, including church. And there is some evidence indicating that people with serious mental illnesses do turn to these individuals for support in their lives around work and going to school and those kinds of things. But we also know that individuals with serious mental illnesses, again, have smaller social networks. They have fewer friends. They're sometimes not in contact with family members. Maybe they don't talk to their neighbors as often as the general population. And what that means for us in promoting community inclusion and community participation is a need to support someone in reconnecting with friends or family members and engaging those friends and family members, or supporting the person in engaging those individuals in supporting them in, again, going to work or school or dating or hanging out or doing any of those kinds of things. So using and engaging natural supporters is important for promoting community inclusion and participation. And the last type of support technology that we like to emphasize is peer support. And there is good evidence that peer support, interactions between individuals with lived experience of a mental health issue with a peer can have positive benefits in a lot of ways for individuals with serious mental illnesses. Let's talk about, and I'll talk about why that's particularly important for community inclusion and participation in a second. I did want to briefly mention some strategies that have been used and used to promote the building of natural supports. The first one is a type of program called ComPeer, and ComPeer started in Rochester, New York in the 1960s, and this there is some evidence supporting ComPeer. Basically, ComPeer involves connecting community volunteers with an individual with a serious mental illness, where both agree to get together one time a month for at least 4 hours for a year. So it's a year-long commitment where they basically get together and get a coffee together or go to a movie or go to a restaurant or otherwise engage in leisure and recreation activities that both people are interested in. This is not a, the community volunteer is not a service provider. This isn't a mentoring relationship. These are reciprocal relationships that are trying to be established where both are basically becoming friends and spending time with each other. So that's one type of strategy that could be easily used to build natural supports. Another one is was developed by an organization called Alternatives, Inc. in Western Massachusetts. They've developed a similar type of program to ComPeer, but they call it Club 21. This is a group of around 21 people, some people who have serious mental illnesses and some people who do not, and they get together as a group to share similar interests or learn about things, or maybe a big book club or something like that. And they also get together in dyads, 2 people going out to do something, or a small group that has similar interests. Maybe 4 people like to go fishing, and those 4 people get together to go fishing. So this is another strategy that could be utilized. The last one that I'll talk about is called circles of support. Circles of support comes from the intellectual and developmental disabilities community in the 1960s. The idea is that staff people, this could be a peer specialist, for example, supports an individual with serious mental illness in identifying things in their lives that are important to them, that they'd like to do. I want to go fishing more. I'd like to go to more movies. I'd like to spend more time with friends. I'd like to start dating again. And this paid staff person will help the individual identify people in their lives who they would like to ask to support them in achieving those goals. So it's not asking people, and those people could be, again, family members, cousins, neighbors, co-workers. It could be anybody. It could be a peer in a program. It could be anybody that that person chooses to ask to support them in doing the thing they want to do. So it's different. So the real focus is on supporting the person's participation in the community, and that is viewed as a likely successful approach for promoting community integration and inclusion, and it's not just focused on paid supports. These are getting those natural supporters who are available 24 hours a day, 7 days a week, sometimes, available to people to talk with them about issues or strategize about how to do that, or even go with them to engage in some of these types of activities. So that is called circles of support. I mentioned earlier that I think peers and peer support in particular is essential for promoting community inclusion and participation. And the reason for that is basically that question at the top of this slide. Who knows better how to live in the community with a mental illness than somebody with lived experience? We found in some of our work that peers are very helpful in supporting their peers and identifying community participation interests, whereas maybe other non-peer providers might have a little less interest in doing that. Peers are helpful in helping someone develop knowledge about their interests and identifying resources that are available in the community. They can help connect people to those supports and community resources. And they're also helpful in identifying and addressing barriers that might prevent somebody from participating in the community. I wanted to mention one particular program that is a peer-run or peer support program that focuses on community inclusion and participation. This is called the Community Recovery Connections Program, and it's at the Bedford, Massachusetts VA. That's a Veterans Administration facility that supports people, veterans with serious mental illnesses who have been involved in long-term hospitalizations. Basically, they have 4 teams of peers who work in 4 different areas where people are discharged from the Bedford VA. Those peers have become very familiar with the community resources that are available for people with serious mental illnesses, the educational institutions, community colleges, the community centers, the Ys that are available, the churches, synagogues, and mosques. They get to know the things, the mainstream resources, we call them, that are available out in the community, and they start having conversations with the veterans about their interests prior to their being discharged, and then support them once they are discharged in the community to access these community resources and support their participation in those community resources. And again, this is a peer-delivered program in Bedford, Massachusetts, at the Bedford VA. Fundamental number 5, providing support to families and other natural supports promotes community inclusion and community integration. The evidence behind this is that, first of all, family members of individuals with serious mental illnesses are also less likely to be participating in the community compared to the general population. We have clear evidence that family members are working less, less likely to go to school and spend time with friends or engage in leisure and recreation activities and those kinds of things. And it is partly related to their supporting their loved one who has a serious mental illness. The reason that this is important is that these natural supports, just like I mentioned before, family members in particular, are an essential resource for promoting community inclusion and participation. So it is logical that supporting family members in their own community inclusion and participation, especially with their loved ones, is essential for promoting community inclusion and community participation. There are a lot of strategies that are out there for supporting family members. Some are things like family to family and other NAMI programs. Family psychoeducation programs are important for supporting family members. And so are initiatives that support families around leisure and recreation, for example. This is a toolkit that our center has recently developed to, in this case, support parents with mental illnesses around their leisure and recreation activities with their children. So this is, again, a way of focusing on the family unit and participation of the family unit in order to promote community inclusion and participation. And again, our website has a number of resources like this, and if you want to contact me, I'd be happy to point you in the direction of others that we have as well. Fundamental number 6, environmental barriers must be identified and addressed. What do we mean by environmental barriers? We mean those things outside the individual with a serious mental illness that limits their community inclusion and participation. There's a concept called social model of disability that people, that is now the commonly subscribed perspective on understanding disability. And this is in contrast with the traditional perspective on disability that is oftentimes called the individual model of disability. The individual model of disability views disability as being inherent within the individual with a particular impairment. So the example that I like to use is John, who's been diagnosed with schizophrenia. John has schizophrenia. That means he's disabled. The impairments are with him. The reason that John doesn't work or go to school or date or parent or is engaged in leisure or recreation, all of these things is because John has this illness. And that in order to reduce the disability, which is his illness, we need to provide good medications and therapies and case management and other services to address John's disability. That's the individual model of disability. The social model of disability views disability as resulting from a poor person-environment fit. There's something about John that doesn't, and his uniquenesses and abilities that doesn't interact well with the environment. So there's no overlap between who John is and the environment. And that lack of overlap or fit is what creates the disability. The disability isn't in John, it's the poor fit between John's uniquenesses, and that could be unique behaviors or ways of thinking or whatever, and the environment. So a good example, is John might talk to himself or be awkward in interacting with individuals, with an employer who's doing an interview to hire them. If the employer is, but otherwise John might be able to do the job. If the employer is somebody who automatically doesn't hire somebody who is awkward, that is going to create a poor person-environment fit, and that employer won't hire John. That's where the disability comes from. The employer doesn't hire John. It doesn't mean that John can't do the job. It just means that there's not a good fit there, that the employer isn't fitting with the uniquenesses of John. The reason I'm mentioning this is that social model of disability means that we need to pay attention to the environment and environmental factors that affect participation and inclusion of people with serious mental illnesses. Sometimes we talk about these factors as social determinants of health as well, these environmental factors outside the individual that affect health. So some of the factors that undermine, environmental factors that undermine community inclusion and participation for people with serious mental illnesses are policies and practices that disempower or take away voice of people with serious mental illnesses. Poverty is something that limits inclusion and participation. Transportation limits community inclusion and participation, and prejudice and discrimination is likely the biggest factor that limits community inclusion and participation. So this fundamental suggests that we need to, in addition to providing supports and supported employment programs and other efforts, provide good treatments and medications to people in order to promote inclusion and participation. We also need to address these environmental barriers that limit inclusion and participation. So some strategies for doing this is to, first of all, eliminate prejudice and discrimination. There's a concept called the contact hypothesis. Basically, the more contact that the community has with people with serious mental illnesses through speakers bureaus, presentations, these kinds of things, the more reduction we see in prejudice and discrimination. And you see some other strategies here that have been used. What's critically important, especially around prejudice and discrimination for us to think about, is that our current efforts at addressing this have not been as successful as we would like. Our May is Mental Health Month. Our second week of October is Mental Health Awareness. Our public service campaigns are not having as big of an impact on reducing or eliminating prejudice and discrimination as we would like. And unfortunately, that prejudice and discrimination is also keeping people from services as well. And I do like to say that it's really important for us to focus on reducing prejudice and discrimination every day, 365 days a year, all the time, with our friends and family members and everyone we come into contact with, because we need to do a better job at reducing prejudice and discrimination that people are experiencing. The last fundamental that I'll talk about this afternoon is the need to maximize the use of mainstream community resources. I referred to these community resources earlier when I mentioned things like community colleges, YMCAs, gyms, all of those kinds of things would be examples of community resources. Churches, synagogues, mosques, vocational programs that are available to the general population, anything that any other citizen of a community can use, those resources, we should also pursue the use of those resources for people with serious mental illnesses as well. So basically the idea here is we don't just need to depend on resources within the mental health system. We should also be looking outside for services and supports and things that people with serious mental illnesses can use out in the community. Some of the evidence around this is that, first of all, there are lots of resources out there that we oftentimes don't think about obtaining or using with people with serious mental illnesses. And we have many more of those resources than we'll ever have in the mental health system. We'll never have enough funding for promoting physical health and wellness. Gyms, we'll never have enough funding for education programs or work programs or those kinds of things. That we really need to look for these services and resources that any citizen can utilize. So that's critically important. So some examples for doing this, I referred before to that Recovery Connections program in Bedford, Massachusetts. The peers in that program actively go out into the community to understand what resources are available in that community and then try to connect those resources to meet the needs and interests of the veterans with serious mental illnesses that they're working with and supporting. And again, these are a list of some of the types of community resources that all of our communities, all the communities that you work in have. And it's very important for us to know what is out there and then support connecting people that you're working with those particular resources. So I think I came pretty close to my 55 minutes after the hour target. I've got 57 minutes after the hour. So now is the time for your questions and comments about what I've been talking about.
Thanks, Mark. This is Ashley. I just want to also encourage people, if they'd like to type a question into the chat box, that would be great too.
I can say, actually, I do have a question for all of you, and I asked this at the very beginning when I was going through the objectives. I'd be very interested in hearing what you're currently doing in your AOT programs to support community inclusion and participation. Even if it's a small part of what you do, I think it would be really helpful to share that with some of your colleagues in this group. Or you could talk about some of the challenges that you think you either currently face or might face in supporting community inclusion. So it looks like somebody's typing a comment or a question now. So it looks like Beatriz is writing that I assume PR is Puerto Rico.
Yep,
we've been working to be able to achieve our participants' educational goals, which is outstanding. It's great to hear that your program, your initiatives are focusing on educational goals for individuals. That's terrific. Are other programs focusing on these kinds of things in addition to supporting people in getting medications and therapies and other types of services and supports related to their mental health condition? Are other people focusing on these kinds of things as well? Yes, and Beatriz, again, I love that you guys focus on it. And this actually, you're mentioning many have not finished middle school or high school, so it becomes something important. And let me actually, I would love to elaborate on why that is so important. We like to focus on, or it's important for us to focus on, unemployment rates for people with serious mental illnesses. Unemployment is around 75 to 85% of individuals with serious mental illnesses are unemployed. We typically focus on the illness as the reason for the unemployment, that it has to do with symptoms in particular. But we also know that people with lower educational attainment, anybody with lower educational attainment, somebody who only has a middle school or a high school education, that those individuals also have lower employment rates than the general population. People with serious mental illnesses have lower educational attainment than the general population. So in order for us to address employment, it's likely important for us to also focus on educational attainment. Education, as I mentioned before, individuals who are going to school and engaged in education pursuits feel better about their lives. They feel more hopeful. They have better skills in a lot of different ways, and it enhances their chances of working later on. So, so thank you very much. And I see that you also wrote employment has been hard to attain as well. And absolutely, it's hard. It is challenging to support people in employment, but we do have good practices for doing that that do result in employment for people and help increase some income. Sarah from Cleveland, we have a supportive employment specialist who helps clients obtain employment and regular jobs in the community. We've also referred clients to local programs to help them complete their GED, which is outstanding. It sounds like you're utilizing what I call a mainstream resource, this local program around their educational pursuits, and you also have somebody on your team that's focusing on employment. So again, that is outstanding. In terms of your work with the mainstream, that local program, we've worked with some agencies and programs we've worked with some mental health programs who are doing these kinds of partnerships. What we've supported them in doing is reaching out to those local programs and letting those local programs know that the mental health agency is a resource in case something happens or there's a problem, or they'd like to provide more individualized supports for an individual and maybe address some of the mental health issues they might be experiencing. So we really encourage the development of partnerships with those local programs, sometimes to reduce the prejudice and discrimination or concerns that those local programs have in supporting individuals with serious mental illnesses, but also being a resource to those local programs as well, and developing a reciprocal relationship. So they're not just helping you, your program is also helping them, because they're likely also providing services to other people with mental health issues. So how about some of the other sites who are on the call? Are you doing anything related to inclusion and participation? Are you thinking about doing anything that you'd like to share with other people? Well, for those of us on the East Coast, it's after 5 o'clock. I know Utah's here, so you've got a couple more hours of work, but I don't know if that explains some of it. But Ashley, I'm happy to stay on a little longer. I also would ask that if anybody's interested in talking more about these issues, I am happy to email about any of these issues. I'm happy to talk by phone. I'm happy to support all of your efforts, and really thrilled to have the opportunity to support your important work that you're doing, and encourage you to incorporate these concepts and focus on inclusion and participation as much as possible, because I do think it'll add to your success. So please keep me in mind if you want to talk more about these kinds of things.
Yeah, Mark, this is Ashley. That sounds great. And I'm just going to leave this next slide here, the Game Center contact information also. So, everyone can feel free to reach out to us as well if they have any further questions. But no, I really appreciate you speaking with us today.
Great, my pleasure.
Yeah, like you said, it is
All right.
getting late, so if you want to stay on for a few more minutes, that's fine. If anyone has any questions, they can write in the chat box. Otherwise, I'd say everyone just have a wonderful weekend.